Hello, everyone, and welcome to CAMS Menopause Hour. For those of us in Canada, it's morning, but for those in other places in the world, welcome no matter what time of day it is. The presentation that we are going to do today is a collaboration between the Canadian Menopause Society and the International Menopause Society through the Council of Affiliated Menopause Societies. Title of today's presentation is A Practical Approach to the Management of Menopause. I'm Dr. Denise Black, and I will act both as moderator and as one of the speakers. My co-presenter today is Dr. Ardell Piper, and she will discuss early menopause cases, detecting early menopause, its cause and symptoms, risks, prevention, and management. And I will discuss risk factors in mature women's health, how to identify menopausal patients at increased cardiovascular, venous thromboembolic, and cognitive risks, and articulate how lifestyle modification is key to reducing these long-term risks, and discuss how menopause hormone therapy can be safely used in these patients. This is an online event, and it has been supported by an unrestricted grant from Abbott. Abbott had no role in the selection of topics or speakers and have not vetted or reviewed the content of the speakers' presentations. The speakers have been chosen by the Canadian Menopause Society and are receiving no financial compensation for their efforts today. I would just like to tell you a bit more about the International Menopause Society. Even for those that are not members, you can access the website with a variety of educational resources, information about upcoming conferences, World Menopause Day highlights, the IMPART program, which stands for International Menopause Society Professional Activity for Refresher Training. And this is something that is open to everybody. This is a free set of modules to enhance your education. Part 1 has 8 modules. Part 2 has another 8 modules, and this is available free to anybody. So I would invite everybody in the audience to visit the website and find and investigate some of these great educational materials. I'd also encourage you to become a member of the International Menopause Society. It is a very cost-efficient membership, and it provides you with a lot of additional benefits, including access to educational resources, monthly live events, and a much more extensive library of educational resources, and access to Climacteric Journal. The International Menopause Society World Congress this year is in Melbourne, and this is a fantastic conference. It's probably my favorite menopause conference that I go to. So for those that are interested, there's more information on the website, and I would invite you to visit to see maybe this is something you would like to do. So without further ado, I'm going to pass over to Dr. Piper, who will do a brief introduction of herself, and we'll get started.
Thank you so much, Dr. Black, for guiding us into this day today. Can you just confirm that my sound is okay and that you can see my slide deck? Right, good, lovely. So it's a pleasure to be part of this collaborative effort today. My sincere thanks to the IMS for inviting us. And my slides have been made actually in collaboration with Dr. Shafina Premji and Dr. Karen DeRosier from here in Canada, when we presented this series last year. My name is Dr. Ardell Piper. I'm a menopause specialist and I work in Ottawa, Ontario, Canada. I have now pretty much an exclusively virtual menopause consultation practice. And it's my pleasure to be able to share with you this case-based approach that we have created today. Just see if I can make sure I'm advancing my slides. All right, there we go. Okay. Except my slides are not. Yes. So sincere thank you to the companies that helped to sponsor the creation of this original slide deck. And I do have personal disclosures, but they will not impact on the content today. So this presentation today really has an intent to review basic principles of early menopause, such as definitions and consequences and treatment strategies. But the academic component is quite straightforward and based on guidelines. 20 minutes is not enough time to really do a highly academic review of the newest research on early menopause and POI. But the three of us who collaborated really shared our experiences about people who we met in our practices, where the questions were that needed clarification when it came to management, and how to apply then the guidelines that we've created in Canada to actually counseling patients. So this is kind of a progressive walk through the journey of a person who is facing early menopause, their questions and concerns, and then applying these principles of the guidelines to reassure them. And since it is Endometriosis Awareness Month, right on the tail end of it, our presentation does create or use a case of endometriosis. The incidence of endometriosis and the impact deserves way more recognition. And so the Canadian Menopause Society and myself are grateful for this opportunity to advocate for endometriosis care. So the diagnosis and patient journey of early menopause is significant, and it's not the same as menopause that happens at an average age and of natural causes. If menopause has been disregarded and underappreciated, missing opportunity for not only management, but also understanding early menopause has been an even more difficult experience for people. And these are actual quotes from the patients that inspired us to create this presentation today. Whether it's POI or whether it's early menopause from cancer therapy or surgical menopause, when it's completely unanticipated, like POI, or somewhat planned, this early end to ovulations and menstrual cycles can be welcome by some people and have indications, but it can be devastating for others. And there are multiple aspects that really contribute to the negative experience that some have. Inadequate counseling of the symptoms to expect, inadequate access to therapy, the effect of misinformation about therapy, untreated symptoms then, and then unaddressed suffering. And this third quote, actually in the slightly larger font today, was one of my patients. She was referred to me after a TLH-BSO for severe endometriosis. And in our first visit, she expressed that now that she was referred to me, she didn't anticipate ever seeing her gynecologist again, because who would want to see her again when she had lost all of her organs and she wasn't really a woman anymore? This was her actual quote. And it's heartbreaking because people have felt this way all along. They just haven't been expressing this, or maybe we haven't been asking. And so it's really important that we more assertively and aggressively address this. And so our case today is Maria. She is a 37-year-old G2P2. She has a long history of pelvic pain and endometriosis. She's had multiple attempts at medical management, all unsuccessful finally. And now that her family is complete, she's contemplating then this total hysterectomy and removal of both her tubes and ovaries. And she hopes that this is going to reduce her pain. But she is nervous. She feels too young to go through into menopause. This really isn't what she wanted, but it's what she feels is necessary. So for the average middle-aged woman, if we go through just general definitions to clarify, menopause is defined as having amenorrhea for 12 consecutive months at the appropriate age. It is a physiologic phase that we expect, like puberty. And the average age is somewhere around 51. Again, that's a loose number because it can vary with ethnicity and with different risk factors. The normal range can be then from 45 to 55. At birth, we know that the ovaries have millions of eggs, and they're already starting to undergo atresia. So with puberty, this is accelerated. Follicles are stimulated to have conception potential. With many follicles being stimulated every month, there's adequate amounts of estrogen around. But the remaining quality and quantity then of eggs is progressively diminishing with time. So the perimenopause can start with up to 10 years before the final menstrual cycle, with variability in menstrual length, with the amount of flow, with the associated symptoms of those cycles. And after that 12 months of amenorrhea is observed, the menopause diagnosis is reached. But this does not mean that women do not deserve menopause treatment up until that point. And that has been a huge myth out there. This has been very poorly appreciated for many years, and it can have perimenopause can have significant symptoms. And our guidelines now do have better suggestions about how to treat both with hormonal and non-hormonal options. However, women who enter menopause under the age of 45 should be assessed and counseled and managed a little bit differently. Early menopause occurs between age 40 and 45. It accounts for about 15% of women. In about 3 to 5% of the time, it's natural. Up to 10%, it's iatrogenic. And sometimes when it's, the natural causes, it might take more than 12 months to really confirm that they've actually had their final menstruation. And so that retroactive sort of diagnosis, is, flexes a little bit around that age. Premature menopause is when a woman enters menopause and under the age of 40. There could be medical and surgical treatments that result in this, in it being induced. There is typically then some anticipation and lead time to prepare for that. And we do need to take advantage of that opportunity. POI is a version then of premature menopause. It's not iatrogenic. It's often not anticipated whatsoever. And the term was changed from premature ovarian failure to better reflect the fact that it is, a premature ovarian aging condition of not having sufficient follicles to take you to the point of average menopausal age. Words like failure are really good for us to be reassessing as a medical community. Women with POI are often already confused about their diagnosis and what they have done to have this then happen to them. So the words that we use really matter, right? So we now refer to it as POI. It affects about 1% of women, but it can affect women of various age groups. 1 in 1,000 are the age of 30, or so one, and less when it comes to ages underneath that, but it could still happen at very young ages. Investigations, should include making sure that it's not secondary amenorrhea for other causes. You could, draw FSH levels, a few months apart in order to anticipate and see a pattern that is specific, rule out other causes. Women, of course, should be off of, birth control pills for a good amount of time before you actually draw these levels. And of course, you can also check FSH when there is an IUD in place, a progestin-secreting IUD in place, causing their amenorrhea. Many causes of POI are idiopathic. There can be a strong family history. Some cases are due to genetic disorders. There's some association with other autoimmune conditions, but in the end, many patients feel frustrated and very much at a loss as to why they're going through POI, and that there isn't really a definitive cause that can be defined for them. And we do know that there are some risk factors related to lifestyle. So, and again, just a quick little reminder here that when you're diagnosing early menopause, it's important to just have a strategy for working up secondary amenorrhea. That's going to have different lab investigations, different results in your FSH, such as a low FSH and low estradiol when there's hypothalamic etiology. Note that, of course, post-pill amenorrhea is common, and so it can take a while after stopping a birth control pill to actually see what ovarian function remains. And for women with secondary amenorrhea, this broader workup then is more important to include things like thyroid assessment and prolactin levels. So if we return then to Maria, she has decided then to go ahead with surgery. She is aware that her surgery may be more complicated because she had level 2 ultrasound, which is a more dynamic ultrasound looking for sticky points, areas where, the bowel and is not sliding nicely against the uterus and against other organs. And so this has resulted then in her being referred then to MIS for the surgery. But she's looking forward to it. Even though she's a bit afraid, she's looking forward to having no more pain. She's looking forward to having no more periods. She's aware that this is going to then result in surgical menopause. But she kind of wants to be au naturel and avoid hormones because she's heard of all the nasty things that hormones can do. So the question then becomes, how do we counsel her appropriately so that she can have the right treatment? Despite the many consequences of early menopause, it's not all bleak for all people, right? Women who have a prophylactic BSO, for example, it could be due to the BRCA mutation carriers, and it will reduce the risk of having cancer later on. Of course, in our case, we're hoping to reduce the impact of the menstruations on symptoms. It can be beneficial for people who have severe migraines or PMDD. And so, and of course, the impact on life when it comes to abnormal uterine bleeding that can really impact on your quality of life. And there can be a significant cost associated with menstrual products. So for many people, not having cycles is great. And it can actually kind of contribute to them being a bit hesitant to start with hormone therapy because they're worried that that is going to bring back bleeding if a hysterectomy has not occurred. So it's really important to be openly discussing then their specific case. But some of these short-term or these immediate impacts of early menopause can be much more severe when it's and POI can sometimes have fewer symptoms. There needs to be detailed counseling about the preventative benefits of hormone therapy, because in POI, sometimes it's such a gradual, slow dwindling that they don't have the sudden and severe symptoms that happen when someone has surgical menopause. That's so sudden. And many people in premature menopause have a healthcare provider that says, oh, it's either too or you're too young, for this to be spontaneous early menopause, and they don't receive appropriate counseling. So if people are actually going to have a hysterectomy and a BSO, some of them have discussed that they wake up feeling like a completely different person, and these symptoms are much more than they ever expected. And we're appreciating now that the symptoms of menopause are more than just hot flushes. And that was an oversimplification in the last number of decades. So whether it's iatrogenic or whether it's spontaneous, it results in it's different than the average population and the average age. And so therefore, without treatment, earlier onset of this low estrogen environment will have impacts to long-term health. And so we can't forget to be discussing the long-term consequences, like heart health, like bone health, like cognitive and brain health. And women in early menopause can have an accelerated risk of these different conditions if left untreated. So it's crucial that we talk about then these physical consequences, and that we really start paying more attention to the psychological and cognitive effects that can greatly impact on wellness, on quality of life, both acutely and then also in the long term. There can be a significant change to people's self-esteem, to their well-being. There could be an increase, of course, in sexual dysfunction. Loss of fertility for some people can severely impact themselves and their relationships and their family units around them. And so it can be very important to have this on the radar and be collaborating appropriately in a multidisciplinary team. Induced menopause and POI are both then associated with increased risk of depression. And so this has to be deliberately and intentionally discussed. Acute major depressive disorder, of course, should be treated as such, but there is an increasing appreciation that mood issues can happen with menopause, particularly if there have been mood issues when other hormone flux states have been experienced, such as with bad mood with PMS or postpartum. And so it can be helpful to be screening for this. You can use tools like the PHQ-9 or the GAD-7. They can be part of your screening strategy. And of course, as soon as you know that people have had mood disorders during pregnancy or with PMS, then heighten that level of diligence. But unfortunately, because there is still some misinformation surrounding hormone therapy, particularly when it comes to concerns of heart disease and clot that were generated from the WHI, a lot of this has been heard by young clients who are not the same demographic group as what classic menopause research is occurring in. And so this can result in an incredible amount of misinformation that hormones should be avoided in these young people because it is a risk for heart disease and it will give them heart disease. This is a vague sort of fear that they have accumulated. But in fact, in younger population, appropriate hormone therapy can have heart benefit. And so we continue to need more research to elucidate the exact etiology, but there could be a negative impact on endothelial function, on metabolic changes, on lipids. And so it's important to be screening as well for risk factors, to be talking about diabetes, hypertension, hyperlipidemia, other things that can overlap and contribute then to those risk factors. More people will get osteoporosis and a fracture than breast cancer. And the incidence of osteoporosis in the POI population could be as high as 27%. They can have a lot of bone loss as well in their spine. And so bone health is an increasingly important disease that we need to be talking about because it really does rely heavily on the prevention strategies. Bone protection is a major reason why we are recommending for appropriate doses of hormone therapy. And the discussion should involve nutrition, adequate vitamin D supplementation, dietary calcium being better than supplements, and of course discussing now weight-bearing exercise and maintaining muscle mass through strength training and resistance training. And osteoporosis is silent. So just like people may not know that they've had hypertension or atherosclerosis until after they've had a heart attack, sometimes it's not until people have had a fracture that they realize that they've had decreased bone quality. And there are cognitive concerns that we need to keep in mind. There is data looking at women who have had untreated surgical and iatrogenic menopause and POI. It suggests an increased risk of dementia and Alzheimer's disease. But it's now in the headlines. There's been a lot of very recent interviews and books that are being published on this and research on this. Dr. Lisa Mosconi, of course, I'm a big fan of hers and following what she does. And what she and how she tries to clarify this message that, again, a lot of these are very multifactorial. There can be a genetic risk component, but we need to be very aware of how early menopause and POI can contribute to this risk profile. So back to our case then. Maria then does come back to your office for a routine vaccination later on, and she gives you an update on how things have gone. She did meet the surgeon. She was told that hormones can be prescribed after surgery. And she was told that even with endometriosis, she can try hormone therapy afterwards. So this is accurate, right? Hormone replacement therapy can be started and is recommended until the average age of menopause. We shouldn't be either suggesting that hormone therapy is somehow safe until 51 and then somehow becomes immediately now risky and dangerous. What can we tell her about her actual therapy options? The guidelines are very strongly supportive of replacing hormone therapy. This is why in Canada, we do really refer often to hormone replacement therapy in this scenario, because it is trying to replace back hormones that should have been there. Rather, using menopausal hormone therapy as the abbreviation that we're trying to lean towards now to more accurately represent, that is therapeutic use of hormones in the menopausal age. And sometimes I think that type of, again, different using of definitions and terminology kind of helps to clarify that for us, particularly for our younger patients. So we do recommend using hormone therapy until the average age of menopause without hesitation. And then it can be continued as needed as kind of more classified as menopausal hormone therapy. Testosterone can be used on a case-to-case basis. We don't have products in Canada that are specifically designed for women, so we are using often gel products in appropriate lower doses. The doses that we use for estrogen are, of course, not only for symptoms, but also to protect bones and heart. Clients in early menopause often need the upper ranges of the available in Health Canada approved doses. And we need to customize that. Sometimes we might need to go a little bit above that because, again, those products have been approved for average menopausal age women. And so if in these younger populations, sometimes you need to have higher doses in order to get their symptoms under control. We generally focus on the estrogen as being proven to have so much of that benefit. If there still is a uterus, then of course, progesterone is non-negotiable. And even if people have had a hysterectomy, such as in endometriosis, it can be advantageous to use add-back progestogen of some sort to reduce the risk of any endometriosis implants being stimulated then by the estrogen replacement. And there's a significant amount of misinformation here to clarify again, right? Hormone therapy given to younger women is going to be much lower than what they made in their natural cycles. So again, this sort of attitude out there that hormone therapy itself is a risk. And therefore, the clock starts ticking as soon as you start it, that at 5 years or at a certain age, now you've hit your max of how much exposure to hormone therapy is considered safe. This is a prevailing myth that we really need to be continually educating and addressing. We cannot ignore the guidelines that clearly encourage individualized discussion and risk assessment. This is not just superficial and about annoying, bothersome hot flushes. This is about serious consequences to quality of life and serious implications for long-term health down the road. And outcomes of untreated premature ovarian insufficiency are clear. So in prepping Maria for surgery, there are things that we want to counsel her about as she starts then making an informed decision about hormone therapy. Patient education, providing with good evidence-based resources, online reading, books, better understanding, listening, offering empathy, having that psychological support if possible, and discussing then the health promotion and prevention through lifestyle, through modifications, heart healthy life choices, not smoking, reducing or eliminating alcohol if possible, regular exercise, 3 days a week of strength training, decreasing your risk of osteosarcopenia, a diet that focuses on whole foods and adequate protein intake, reducing refined sugars. There's lots of things that we can counsel about that really help clients realize that we are interested in their whole wellness in going through this experience. Long-term follow-up really has a very important impact then to be ensuring that that there's continued reduction then in these long-term impacts of early menopause, particularly when it comes to bone health. Prevention is so key. So these in-depth discussions with clients around the need for vitamin D supplementation, the calcium by diet, directing them to, say, Osteoporosis Canada. In Canada, that's where we refer people to often. And then doing other things like routinely screening for cardiovascular disease risk factors, height, BMI, lipid profile, using a Framingham risk calculator. If there's a designated POI or early menopause clinic in your area, refer and see if there could be some multidisciplinary support there. And then how do we actually counsel about the hormone therapy options? Many people will ask, many of our clients ask about compounded products. They think that these are somehow natural and safer, or over-the-counter herbs and supplements. So this conversation needs to continue so that you can kind of nip all those in the bud as well and find out where our clients who are young and intelligent and continuing to do research, where their questions continue to come up and where their misinformation might need to be corrected. So thankfully, Maria understands then that hormone therapy is beneficial now, not only for symptom relief, but for quality of life and for long-term benefits. So to prepare herself, she did Google search some keywords: safe, hormone therapy, cancer, etc. And now she has questions then about bioidentical therapy, which she heard is natural and then isn't going to cause breast cancer. So first off, there is no universal standard for how to prescribe hormone therapy and for people in premature or early menopause. The goal is to provide a regimen where patients have adequate symptom control, a sufficient dose to provide heart and bone protection, and then one that will be sustainable in the long run, that someone will use for a prolonged period of time. So it's crucial then to be screening for and using a regime that will minimize negative side effects like breakthrough bleeding, and that we manage people's fears around risks of hormone therapy so that we can increase that long-term benefit. So for women specifically with spontaneous or idiopathic POI, it's important to keep in mind that hormone therapy does not provide contraception. And so in those cases, then there can be spontaneous ovulations unpredictably. So that those might be situations where, of course, you need to discuss some contraception. That can be a reason why a combined hormonal contraceptive may be a good option for them. There are different varieties now available that aren't just the ethinyl estradiol, but might have different types of estrogen in them, such as estetrol in Canada. We now have one product with estetrol. And of course, they can also choose a hormone replacement therapy regime. Sometimes the CHC and the combined hormonal contraceptive can feel a bit more age appropriate to people, and so they may prefer it. But in general, if we're using hormone replacement therapy, we can feel confident then, again, as mentioned before, using those doses at the higher range. The best treatment option is the one your patient's going to accept. And so for people who really want to have some sort of bleeding or period, psychologically, they may feel that maybe if it's POI, they might want to keep a bleeding pattern of their endometrium if they want to pursue IVF and such. And so all these things contribute. In the 2021 menopause guidelines in Canada do have a list of all the available hormone therapies. Our Canadian Menopause Society has on their website a pocket guide available as a PDF, which has really nice succinct charts of all of the tables of estrogen options, progestogen options, combined options, vaginal therapy, local options, the non-hormonal options. And so those resources are available for you to make choices from. So an example, again, this is just one example of the many different ways that you can choose to treat. You can use patches, again, at the higher levels of the doses. You can use larger quantities of the gel. I find that people often have less tolerance for these large doses of gel covering multiple surface areas. And so sometimes the patch is a better choice there. If these people are at low risk, they shouldn't be afraid of using oral estrogen. Again, that's a bit of misinformation out there. And micronized progesterone can be used at the appropriate dose. If there's a uterus, then it needs to be the higher doses of it, or a progestin IUS. But consider which type of progestogen is the best for your client. And so in endometriosis, and specifically in Maria's case, there aren't really universal guidelines for what we should use either. There is agreement, of course, that the benefits of hormone therapy outweigh risk. Unopposed estrogen might increase the likelihood of implants regrowing, particularly in severe disease. And so it can be a good idea, and there is consensus that offering add back progestogen can be beneficial then, or you can use some of these other options like a TSEC, something else that will suppress endometrium stimulation. So for her, then her TLH and BSO went well, adhesions were there. She was able to access some pelvic floor physiotherapy. She did choose a hormone therapy regime. She felt well, didn't have menopausal symptoms, and she was very happy with her choices in the end. However, 5 years later, she is back in again in your practice. She's got some vaginal itch. She's wondering if she's got some yeast infections. Speculum exam reveals that she has genital urinary syndrome of menopause. And when you do on history taking, you find out that she stopped the hormone therapy. She heard it was dangerous to be using after 5 years. And she's wondering what now to do about these hot flushes because she's tried everything. And she feels like a failure that these symptoms are persisting for her. So again, this is one of the most important take-home points today. Hormone replacement therapy really benefits from this long-term follow-up for counseling, reassuring people, answering those questions again, reminding that we're replacing hormones, that we don't stop at arbitrary endpoints like 5 years or 10 years or, age, 45 or 50. When they're at the average age of menopause that their peers are experiencing, then you could continue the conversation that it's okay to continue on. That's a shared decision-making process of risk and benefit analysis. And if people do choose to stop their systemic hormone therapy, then it's really crucial to then be having the conversations about bladder, vulvar, vaginal health, the whole genital urinary syndrome of menopause, having a good, thorough discussion about all the local therapy options available. I put a slide of lubricants and moisturizing products into virtually every presentation that I make because it really is important that we are comfortable to have the confidence to have those discussions with our clients. So in conclusion then, premature and early menopause can have profound effects, and these include psychological effects. And so we really need to grow our empathy and understand our patient's experience. We need to do the appropriate investigations, provided there are no contraindications, then we should be discussing CHC or hormone replacement therapy, whatever is appropriate for our client. We need to be mindful of uterus being present and how to be appropriately prescribing in that situation. There need to be adjustments with time. And we can continue this for our early menopausal patients, longer than previously we appreciated. Vaginal therapies are really important to add either to systemic therapy. Often at the higher doses, it's not required, but as the doses come down or if they discontinue systemic therapy, the local products need to be a part of our treatment strategy. And the multidisciplinary approach is really beneficial. There are some resources that I often recommend to my clients on websites because they like being online. I really appreciate this book, The Complete Guide to POI in Early Menopause by Dr. Short and Dr. Leonhardt. It's a book that I always have on my desk that I'm promoting to my clients. And in Canada, we're also lucky to have some very good endometriosis resources. And we're all, pursuing a center of excellence approach wherever possible. And so these are also there for your benefit, for your reference. And with that, I'm going to hand things back
Great.
to Dr. Black.
Thank you very much, Dr. Piper. I am going to share my screen and continue on with the second part of this presentation. I'd just like to take a moment to remind people that if they do have questions, please put them in the chat. And our goal is to have some time left over at the end to discuss this. So I'm now going to switch gears and talk about management of patients with increased risk. We talk a lot about, prescribing hormone therapy to patients. And part of the evaluation of a patient is to see if they have any increased or enhanced risks. And I hope that by the end of this, you will feel comfortable knowing how to identify those patients and how to prescribe to them. So these are my disclosures. Again, goals today: acquire the skills in identifying the patients at increased cardiovascular and venous thromboembolic risk. Reinforce that lifestyle modification is key, but also understand that for a lot of patients, this is the hardest thing that we will ever ask them to do. And then finally, to understand what is the role of transdermal estrogen and micronized progesterone, or transdermal estrogen with levonorgestrel IUS in these higher risk patients, to help provide them protection and safety. So our case today is Ms. Just Can't Function. She's 53. Her last period was 2 years ago. She's having terrible hot flushes and night sweats. She cannot cope with anything that's going on in her life. She's gained a bunch of weight. She's on thyroid replacement and venlafaxine for mild depression. Her mother has had breast cancer. She's got borderline hypertension. Her BMI is 33, borderline diabetes, lipids aren't fantastic. Please help her. When we talk about optimal management of menopause, we talk about, first of all, symptomatic management of menopausal symptoms. And, we have to take patients' symptoms seriously. They are not taking time out of their life to come visit us to talk about things that aren't important to them. So take the symptoms seriously. Reinforce that there is safety, absolutely proven safety for hormone therapy in younger women that are appropriately symptomatic. And there are options that are both hormonal and non-hormonal. Even if a patient is not coming to you with severe symptoms, remember that midlife is a time to maybe reset and to relook at other health risks. Pay attention to asymptomatic problems that occur after menopause. Talk to people about heart healthy habits. Have a chat about BMI, blood pressure, glucose, exercise, diet, lipids, not smoking, all of the things people want to hear about. And also be aware that because of changes in fat deposition after menopause, there is an increased risk of diabetes. When we talk about optimizing cognitive health, remember things that are good for the rest of your body are also good for your brain. And we have an epidemic of cognitive dysfunction among aging people. And the time to start talking about cognitive health is early in life, even before the menopause transition. So important components: heart health is brain health. Keep the heart healthy by treating hypertension, dyslipidemia, and diabetes. A blood pressure of 120/80 or less optimizes brain health. Encourage patients to be smoke-free, to stop excessive alcohol intake, to stay connected socially, especially if they have a history of depression. One of the lessons from the pandemic is that isolation for some people is very bad for neurocognitive decline. Exercise your brain, do Sudoku and the crossword puzzle, learn a new language, go to Melbourne for the IMS meeting and, see a new place. Encourage and exercise your brain. Counsel patients on the importance of weight management and physical exercise to lower dementia risks, right? Train the body, boost the brain, maintaining vigorous exercise, and slowing midlife weight gain, especially by use of the Mediterranean diet, which is somewhat anti-inflammatory, has been proven to be beneficial. So all of these things help your brain to age. Flipping back, what are the indications for systemic menopause hormone therapy? Well, it depends what guidelines you choose to follow. The Canadian guidelines, the SOGC guidelines, say the indication for treatment is vasomotor symptoms. If you just go south of the border, the Menopause Society guidelines suggest treatment of vasomotor symptoms and prevention of osteoporosis. If you go globally, the IMS guidelines are a lot more permissive. Other menopause-related complaints, muscle and joint aches and pains, mood swings, sleep disturbances, and sexual functioning all may improve during hormone therapy, but all of the guidelines reflect this same mantra. Initiation prior to the age of 60 or less than 10 years from the final period carries the least risk and the greatest benefit. So what are the contraindications to systemic hormone therapy? The contraindications to estrogen are listed on the left, and I think these are ones that are all familiar to us, but I'd just like to bring attention to the contraindications to progestogens, which you can see visually are much fewer. 2 contraindications: current personal history of breast cancer or undiagnosed abnormal vaginal bleeding. This opens up use of progestogen-only therapy to a larger number of women, and progestogen-only therapy can reduce vasomotor symptoms by 60 to 65% and can be very useful for people where there may be a contraindication to estrogen. So back to Ms. Just Can't Function. Does she have an indication for hormone therapy? Absolutely. Severe vasomotor symptoms affecting quality of life and the host of other things. Does she have contraindications? No. If you noted on that list, family history of breast cancer is not a contraindication. And in guidelines, this is very, very clearly stated. People with a family history may have a slightly increased background risk due to genetics, epigenetics, environment, etc. The addition of menopause hormone therapy does not appreciably increase the risks. Is Ms. Just Can't Function at increased cardiovascular or VTE risk? Absolutely. She has an increased BMI. She's got borderline blood pressure, her lipids are a bit out of whack, and she has prediabetes. So this is a patient that we would identify at increased cardiovascular and VTE risk. So what do we do about these women? Is hormone therapy contraindicated here? So the guidelines are actually very nicely aligned. When we take a look at the International Menopause Society guidelines, the Menopause Society, Practice Pearl, the SOGC guidelines, even the Endocrine Society, all of them are aligned, and it basically goes like this. For women that are at increased risk of cardiovascular disease or increased VTE risk, transdermal estrogens are preferred. If progestogen is necessary, micronized progesterone is preferred. The levonorgestrel IUS is also an option in these cases. So all of the guidelines concur that if you have an increased risk patient, that's your transdermal estrogen plus micronized progesterone or levonorgestrel IUS if endometrial protection is necessary. For venous thromboembolic risk, we know that hormone therapy is just one small piece of the puzzle, right? You have to kind of have that Swiss cheese phenomenon going on where there are multiple things that coalesce and come together to cause a clot. Now, hormone therapy is one of the things that in individuals so predisposed can have an impact, but truly age is the single biggest risk factor, okay? As you get older, the risk of venous thromboembolic events rise, and starting kind of around 60, you can see that the slope of that really does begin to change. So age is an important contributor. What about obesity and VTE risk? Well, there is good data that people who are obese have an increased risk of VTE, and the use of low-dose transdermal preparations in this review was 50 micrograms of estradiol patch. Low-dose transdermal estrogen did not further increase this risk over the elevated baseline risk. So this is the evidence for use of transdermal estrogens in people who are obese. For people that have had a previous venous thromboembolic event, again, there is some evidence that transdermal estrogen at low dose, again, 50 micrograms or less, does not increase the risk further over the elevated baseline risk. So this is where the suggestion that even if someone's had a previous VTE, use of a low-dose transdermal estrogen may not increase their risk. For people with prothrombotic mutations, again, these people have an elevated baseline risk of developing a clot, but again, small numbers to the studies, the use of a transdermal estrogen at a low dose did not seem to appreciably increase the VTE risk above their elevated baseline risk. So in those populations, hormone therapy is not contraindicated, but use of a transdermal at a low dose is important. What about patients with increased cardiovascular disease risk? What is the impact of route of administration in these patients? So I'd just like to take a moment to say that in women, modification of cardiovascular risks is especially important because if you're a man and you have one risk factor, it increases your risk of cardiovascular disease. If you throw in another risk factor like diabetes, it increases it a little bit more. But if you are a woman one risk factor plus another risk factor does not equal 2 risk factors, it equals 4, right? So if you are a woman with hypertension and diabetes, you have 4 times the increased risk. For women, modification of cardiovascular risks is especially important. What we know about hormone therapy in smokers is that they have an earlier natural menopause and often have worse symptoms with a higher incidence of symptomatic GSM. Smoking is not a contraindication to hormone therapy, but because of the way the liver in a smoker metabolizes estrogen, orals do not work as well. So for smokers, transdermal estrogen is more efficacious. For those that have blood pressure issues, hormone therapy is not contraindicated. We know that after the menopause transition, hypertension becomes much more common in women, and most hormone therapies do not have a deleterious effect on hormone therapy. So most therapies do not have a deleterious effect on blood pressure in normotensive or hypotensive younger postmenopausal women. And when making decisions about the suitability of hormone therapy in women with pre-existing hypertension, consider the presence or absence of other cardiovascular risk. If it's isolated, mild hypertension that is well treated, that woman can sort of choose whatever hormone therapy she likes. But if a woman has multiple risk factors, hypertension plus diabetes, that may be someone where a transdermal estrogen has benefit. So what is the effect of hormone therapy on lipids? We know that lipids do change quite dramatically from the year before the final period to the year after. Triglycerides increase, apolipoprotein B increases. All of them are quite substantial increases. Now, what we know is that oral estrogens cause favorable alterations in the lipid profile. Transdermal estrogens are neutral, but these are not so significant that they alter cardiovascular risk. It's more of that category of, yes, it's statistically significant, but may not be clinically significant because the protective effect of HDL-C might be lost after menopause because of the increased total body inflammation. So for those who have hypertriglyceridemia, oral estrogens increase triglycerides. So if a patient has elevated triglycerides, transdermals are preferred. And women who have higher cardiovascular risk, perhaps due to a familial hypercholesterolemia syndrome, these women should be carefully evaluated with further investigations, such as coronary artery calcium or carotid intima media thickness investigation prior to deciding to initiate MHT. We're not going to find too many of those patients in our practice overall. So diabetes, we have, again, a lot of evidence that diabetes increases after the time of menopause. For women who are using hormone therapy, especially oral estrogens, there is a reduction in type 2 diabetes diagnoses after menopause. So that's an important thing. If a patient has multiple additional risks, obesity, hypertriglyceridemia, increased VTE risks, no brainer, that's your transdermal patient. With respect to stroke, for those that initiate hormone therapy less than 10 years from the final menstrual period, the risk of stroke is not increased. Now, there's a study, a ReNew study, that is erroneously quoted as evidence that transdermals are safer than orals for strokes. Yes, the patients in the group had an average age of 70, and those that were on orals were actually on quite high dose orals. So for patients that are under the age of 60 at the time of initiation, it probably doesn't matter if they're on a low dose oral or a transdermal. So what about choice of endometrial protection? Does that matter? If you have a uterus, you must use endometrial protection, even if you've had an endometrial ablation. For those who are using systemic estrogens after a hysterectomy and oophorectomy, if they have severe endometriosis, it is recommended that an endometrial protection agent is added, although there is limited data for that. Women who do not require endometrial protection are those who've had a hysterectomy, and those who are using local vaginal estrogens at usual dosing. There is evidence that the 52 milligram levonorgestrel IUS provides adequate endometrial protection for up to 5 years. Now, that doesn't mean that at the end of 5 years it doesn't. All it means is that the clinical studies have only been up to 5 years. So with the levonorgestrel 52 milligrams, 100% of patients had an atrophic endometrium when they were using slightly higher doses of estrogens than what we currently use. So you can safely say that if a patient has a levonorgestrel IUS in place, that for 5 years, that is adequate for endometrial protection for menopause hormone therapy. If you are going to be using micronized progesterone, it's important that it be dosed adequately. And most of the studies to this point have been done with 200 milligrams for 12 to 14 days per month. Vaginal micronized progesterone may also provide endometrial protection for 10 days a month or every other day at 100 milligrams per day because it's absorbed a little bit better vaginally. Transdermal micronized progesterone, which is not available as a Health Canada approved product, does not reliably provide endometrial protection. So with respect to cardiovascular health, we know that micronized progesterone is better for lipids than other synthetic progestins. We know that your choice of endometrial protective agent may also modify your VTE risk, with micronized progesterone, again, showing less effect on VTE risk than synthetic progestins. So back to Ms. Can't function. She doesn't have any formal contraindication. She does have an indication. She is at increased both metabolic and thromboembolic risk. You counsel her on all of the lifestyle stuff, which again, everyone loves to hear about, and you review her options for management of her vasomotor symptoms. She is interested in hormonal options because she knows this is the gold standard and the most highly efficacious treatment. Based on her profile, you quite correctly recommend transdermal estrogens at the lowest dose that will monitor symptoms, combined with either micronized progesterone or a levonorgestrel IUS, which, oh yes, she just remembers she had one placed a few years ago for her heavy menstrual bleeding. So that takes one decision off of our table. So you give her a prescription, and there's two equally acceptable ways to do this. You can give her a 50 microgram patch, which is still considered low dose, and titrate down as her symptoms come under control. Or you can start with a lower dose patch, like maybe a 37.5, and titrate up after 8 weeks if her symptoms are not well controlled. If you are using a transdermal gel, you can start with an estradiol gel, 1 milligram, titrate down to 0.5, or start at 0.5 and titrate up. Either or, she needs a follow-up visit with you so that you can evaluate how she is doing. So I'm going to stop there so that we have a few minutes for questions. I would just like to remind everybody on the call today that joining the Canadian Menopause Society is a very cost-effective thing as well. It's $150 a year. You get reduced registration for regional and national menopause conferences. You get reduced registration and the group of benefit for signing up for international conferences, which is quite a substantial discount. You get exclusive access to the members only area on the website, which includes access to social media platforms where you can get questions asked and answered. You also get access to a limited quantity of some of the printed materials and a whole bunch of other things. So consider becoming a member of the Canadian Menopause Society, and there is the website there. So I am going to stop at this point, and I'm going to find some questions that are in the chat. And if you just give me a moment here, it timed out on me. And Ardell, I'm going to start asking some questions here.
All right.
All right. So, and we'll both, I'm not going to have time to screen the questions, so I will just start with them outright. So first question, as a family physician, I have a patient with amenorrhea, oligomenorrhea under the age of 40. It seems I can do the appropriate blood work and make the diagnosis of POI. Should I refer every case to genetics?
The guidelines, aren't. I've read that some people would suggest yes, but I do think that needs to be tempered with, is the person 39 or is the person 29? What's the family history? Any physical characteristics? Of course, Turner syndrome and different things may have some physical characteristics that really do clarify things. And I think sometimes the client's own anxiety or concern about this can be beneficial as well, right? Yeah, a similar type of example, say with BRCA mutation screening. Some people need to be contemplating a referral to genetics and have that discussion as to whether or not they qualify for the testing. So I don't, even though I know that the guidelines would say that under 40 genetic analysis is indicated, I think there can still be some thought put into that decision. What would you say, Dr. Black?
So again, I think each patient on an individual basis, assessing if there's a strong family history or something, then you may want to investigate. But again, case by case basis, I think is a good mantra. So here's a very interesting question that I will pose. A patient has severe hot flashes and night sweats. She's 54, had an MI a year ago, occasionally smokes. Those two don't go together. Is on an anticoagulant. We are wondering if cautious use of menopause hormone therapy is a valid option. She's tried many non-hormonal things, and none of them work well for her. Is, in this woman, being on an anticoagulant enough that we can say it's okay to start MHT?
What were her list of risk factors again? She had an MI already. Does she have a hysterectomy? Would this be estrogen-only therapy?
No, she hasn't had a hysterectomy.
Well, I mean, I've had cases that are similar to this, and I communicate with their vascular and thrombosis team. I've had some interactions that they would say, yes, if they're anticoagulated, then you have appropriately reduced, then that thromboembolic risk of the estradiol. But sometimes it depends on, it's a multifactorial risk assessment, right? So I think, again, it's not, in my practice, it hasn't necessarily been an absolute no, but it needs to be very cautious. And I think it has to be the multidisciplinary approach of good communication with the team.
Yeah, so again, I hardly ever give a hard no to anybody, but this is going to get close to a hard no for me just because of her history of her previous MI. And I mean, if this was an atherosclerotic MI, this to me is very close to a hard no for estrogen. Remember, the contraindications to progestogens are less.
Yeah.
So this might be a patient where micronized progesterone, because again, at doses of 200 milligrams to 300 milligrams at HS, at those doses, it can provide good relief of hot flushes. And again, from limited trials with the use of micronized progesterone, it doesn't appear to increase the venous thromboembolic risk. So this might be a patient, after again discussion with everybody, that I start out giving progestogen-only therapy as micronized progesterone. So, yeah.
And I think
question.
that it's becoming more interesting, these cardiac events in women who are kind of in the late perimenopause phase, because SCAD can be in there. I've had a client recently referred to me where she actually had vasospasm. She was treated as if she had an occlusive MI for some time before she had appropriate workup, and it was decided that it wasn't actually atherosclerosis related to why she had her event, right? So, I think these are often, like you said, often unique and very interesting cases where it's hard to make hard generalizations.
Yes. All right. So another good question, how do you stop hormone therapy? So if someone has made the decision that they're ready to stop, what are your recommendations for stopping?
Well, again, presuming that we're not going to have a discussion here about why they're choosing to stop. If it is definitively decided that they do want to stop, there isn't necessarily any literature that would suggest it makes a difference if you taper, but I will always taper. I think you probably would as well, Dr. Black, because tapering the dose then lets you see if their intention is, I think I'm fine, I'd rather be off of this, and they start to taper down their dose, and then symptoms come roaring back when they get down to the lowest dose of patch or gel, then maybe completely stopping needs to be reevaluated, right? And of course, then having the discussion about then adding in local therapy. Even if you're getting down into the tapering doses, you might start to see those GSM symptoms start to creep in, right? And so I don't think that it should be a simplistic answer of saying, just stop. I think it really needs to be, a thought through process.
Great. So I think probably the last question, because we're right at the top of the hour, and it's from a viewer in Germany. Thank you for tuning in. I have a 33-year-old patient, underwent a hysterectomy and unilateral oophorectomy at the time of cesarean section for a placenta accreta. So she's now presenting with vasomotor symptoms. What do I do?
Yeah. I mean, that can be a huge risk factor for early menopause, right? That the vascular supply of that remaining ovary might not be the same. You can't predict if that person would have been someone who went through early menopause regardless, or how much that surgery contributed. But if she doesn't have contraindications and she's 33 years old and has one ovary, then it should be a discussion about estrogen only.
Agreed. So I knew that I said that was the last question, but there's one more because I think this is an important point. At what age do you need to stop hormone therapy? And the answer to that is at no particular age, provided that the patient understands the risks and the benefits, and that you see them annually to review if there's been any changes in their health, any contraindications that have crept up, etc., and that they are on the lowest effective dose that that is appropriate. Now, there is the recommendation that sometime in the mid-60s, if a patient's on an oral, that they be switched to a transdermal estrogen, just because of age being the single biggest risk factor for a lot of different, cardiovascular VTE events. But I have this lovely cluster of healthy 80 to 90-year-old women that come in every year without walkers, crisp and clear in their brain, and come in for their refill of their hormone therapy. Now, they may be a self-selected bunch that have taken care of themselves their whole life, but there is no mandatory age of discontinuation as long as there has been discussion about all the issues.
Absolutely. And this is supported in every guideline. So people don't need to be afraid of this.
Yes. So thank you to everybody. There's a whole bunch of other questions that I wish we had time to continue with, but I've been instructed that the top of the hour is the end. So thank you, Dr. Piper. Thank you to the Canadian Menopause Society and the International Menopause Society for making this opportunity available. And to everybody, have a good day or the rest of an evening if you are in other places in the world.
Thanks, everybody.
Bye-bye.